Santosh. Good afternoon, everyone. Welcome to this session, the COVID-19 State Grand Rounds by Department of Health and Family Welfare, Government of Odisha, Bhubaneswar. This is for everyone, doctors of COVID and non-COVID at corporate hospital, ESI hospital, nursing home, dispensaries, clinic, Ayush, and dedicated COVID hospital and dedicated COVID hospital centers. We have many requests regarding different topics, and we'll be taking one after another regarding the rational use of steroids, new drugs like 2DG, and also the case presentations. And you'll be happy to know that along with AIMS Bhubaneswar, the capacity building team of Health and Family Welfare Department will come in the next session with a very pertinent topic, that is the recent change in guideline in investigation and the management outcomes, especially the markers and the drugs. And our speaker is Professor Prashant Raghav Mahapatra, the head of pulmonary medicine at AIMS Bhubaneswar. So one after another interesting sessions, and from next session onwards, it will be a Government of India, Government of Odisha joint program along with SCB and AIMS faculties will join for updating you. So please join in a good number in spite of the cyclone situation. We have come with interesting topic to you. Please join in good number, disseminate, and you'll be happy to know that many people in the YouTube are watching our program, and there are a lot of viewers who have given comments and interacted. So this program is designed for only one issue, that is the antiviral remdesivir. You know, lot many antivirals have come into picture, like lopinavir, like the oseltamivir, and the Tamiflu, and we have used many, but of late we have stick to the favipiravir oral tablets and remdesivir injectables. It has been seen that this particular injectable remdesivir has gone to people have understood the indications and the name of the drug, and there are many queries among people that have you given remdesivir or not. So people are very pertinent in asking that is my patient getting remdesivir or not. So many of the doctors who are related to these attendants and also creating the awareness about their use, they give the impression that the medicine which can save a person is remdesivir, which is not exactly appropriate. So there is a hue and cry for these medicines, though it's a restricted supply by Government of India. We are getting few vials, we are giving to the dedicated COVID hospitals, and the process is on, but it has to be given rationally at the beginning when the drug works, usually in the first week, first 6 days. So with that, we have kept this theme, the rational use of remdesivir in COVID-19. And for this session, the chairperson are Dr. Maya Gantayat, the chief of Ashwini Hospital Critical Care Management, who has shown an exemplary service and the patient care during the COVID pandemic. And Madam will be there today with us. She has already joined. And Professor Jyoti Patnaik, our Professor of Pulmonary Medicine from SU Medical College, will be there. And Professor Preeti Das, the head of Department of Pharmacology from SU Medical College, has already joined. And a speaker is none other than Dr. Sampath Das, the critical care specialist, the pulmonologist, and the in charge of the Ashwini Long Institute at Aditya Ashwini setup at Bhubaneswar. He has been a instrument for the recovery of many patients during the pandemic. He has shown his skill not only as a clinician but as a resource person, as a faculty, and contributed a lot of science during this crisis time. So I welcome all. I welcome our speaker. I welcome our chairpersons. I welcome the panel, and I request our DMT chair, Professor CBK Mohanty, and our additional DMT chair, Professor Braja Kishore Das, to give a short introduction to the theme and start today's webinar. Professor Das.
Good afternoon, everyone. I would like to request our DMD Professor CBK sir to give a short introduction on Remdesivir therapy.
Good afternoon to everybody.
Sir, namaskar.
Namaskar, John sir.
Sir.
Jyoti madam, namaskar. And others who are present.
Maya madam achandi sir.
Namaskar.
Maya madam achandi.
हाँ ମୁଁ ଏଇଠି ଗୋଟେ କଥା କହି ଆଜିର ମିଟିଂ ଟା କୋନଟା ମତେ ଯାହା କହିଲା ବ୍ରଜ ଯେ ମାନେ this is on use of remdesivir. Remdesivir is definitely because it was everybody know that was started long back for treatment of Ebola that failed, and subsequently that has been used for SARS also that failed. But this time that is being used in a very large way throughout across the world, almost in our hospitals. This remdesivir is antiviral drugs. Initially that was claimed that reduces the viral load very rapidly. That is effective. But subsequently there are several trials, many trials they recommend in favor of that. There are also many other trials. They are not able to, they do not recommend the use of this in COVID, either in favor or against. So there are recommendations either in favor or against use of remdesivir in COVID-19. ଆପଣ ମାନେ ଜାଣିଥିବେ ଯେ recently WHO trial ଟା ଯୋଟା complete ହେଲା ସେଥିରେ ବି ମାନେ they had included remdesivir trials, multicentric trials, but final outcome ଆସିଲା ଯେ that failed to meet the endpoints following the trials. ତେଣୁ it has been deleted from the essential emergency use list or use drugs list of the WHO in this end. That has not been formally accepted by the government of India. But remdesivir apna dekhantu je other national guidelines jota achi, for example NIH, National Institute of Health USA, or CDC guideline that follows NIH guidelines, and Infectious Disease Society of America guidelines. These are the main guidelines that is being followed for by the physicians who treat or manage COVID-19 cases across the world. So, although WHO has deleted the name of remdesivir from the list, it is still being recommended for moderate cases or severe cases. But only recommended that should be treated or used early, because unless there it is expected that viremia will come down during the second week. So naturally what would be the role of antivirals that everybody should know. But just imagine, and also please note from your experience that many of us, we are using remdesivir even during third or fourth weeks. Now we have to ask ourselves whether this is rational or irrational in these settings. Any patients who are coming to the hospitals in serious patients, now they are claiming that remdesivir should be given, must be given, and they are also inquiring whether that has been given or not. Tanu, Bartwan, most of the physicians in dedicated COVID hospitals or in big hospitals where COVID patients are being treated, only to satisfy attendance, I will say, Remdesivir is given to the patients. Leave aside because there are controversies whether that is working or not. That is separate. And also I cannot say, because suppose somebody is on ventilator or an IV, etc., recovery again varies. Many patients die, many patients do survive, whether that is because of remdesivir effects or not, because we are now using drug cocktails. We are not using remdesivir alone. We are using now corticosteroids, other immunosuppressants like tocilizumab or JAK inhibitors like that. So every day a new drug is coming. And our young colleagues, our young brothers, now from the day one, they are starting prescribing all these drugs. And yes, for the research purposes, for trial purposes, there are so many new drugs. Those have been included, or those have come into the picture, come into the field of management. But how many national guidelines they have included these drugs? Because most of the national guidelines, they are formulated by a group of experts, particularly experts related to that field. So it is the best time that, so I should suggest that for the time being, we should stick to the different national guidelines. These offline drugs, investigational drugs, or drugs used under emergency use authorizations, so they can be used. But before using these drugs, one should take some precautions. Because no law can protect you. Once you, when you decide to administer these drugs directly without the approval of the family members. For that reason, please note that in case of that favipiravir, you'll get a consent form inside the package itself. The relatives or patients will have to fill it up and will hand over to the chemist before receiving the drugs. So those are also required for remdesivir, because that is a drug approved under emergency use authorization. So also tocilizumab or any new drug, baritinib, whatever. Yes, we have not reached a point where we can discontinue remdesivir at present, because that is still in national protocols. The last guideline that has been published on 17th of this month, that also includes remdesivir for moderate cases, not for mild cases. Moderate cases, that has been included remdesivir, that you can do. And remdesivir is not a safe drug also. There are many side effects, adverse reactions. So we have to take the consent of the patients or their relatives. They must know what are the pros and cons, what will be the chance of getting benefit, what are the different adverse effects. And after obtaining the consent, we can use that. There is no harm. A physician is allowed to use. That is for the safety purpose of the physician itself. And peculiarly in this context, I should say that the government of India has included all these drugs under the headings of either investigational or offline or repurposed drugs like that. But are there any rules or regulations that govern the use of these drugs as per under Drugs and Cosmetic Act? I will say no. There is no such guidelines. There is no such provisions, and this act does not deal with use of drugs under such use. For research purposes, there is another protocol that has been published by CDSO. So that is for new drug trial or research. Again, by adopting that person, suppose you will adopt that principles, means there are so many things you will have to, you'll require to comply. So in clinical medicines or clinical fielding or in hospital setup, you are not using as a trials. You are using as a offline drugs. Offline drug use is the sole responsibility of the physician who decides for it. In India, there is no clear-cut guidelines on the use of offline drugs. So also in many advanced countries. For that reason, so the decision must be taken in consultation with the family members, attendants, or patients themselves. Remdesivir being recommended as an offline drug, you have to follow the principle of use of offline drugs at least for own safety, physician safety. Because suppose something happens, means one may ask, why you have not taken our permission. So at that time, you must be able to defend yourself. You must be able to answer such questions. Yes, till now, Remdesivir is still in the list, and there is no harm that it should be continued. So that will have some effects on the patients. The major benefit is that you can manage the attendance in a much better way. With this, I conclude. I hope subsequent discussions will be more scientific, because I am of the academic field for a long period. I have little knowledge now. With this,
Thank you, sir. Thank you for that nice introduction. And who told that you are away from academic? You are in the helm of academics now, and what you have told is probably the thing which will summarize maybe after 1 hour, after a lot of discussion. So thank you, DMT sir, for your rational approach guidelines and the very important facts you have told to our delegates and also the panel before the start of the webinar. So I welcome all the delegates again, and I'm sure more people will join. And though because of the COVID pressure, we have little less attendance nowadays, many people are watching the program in YouTube even after the discussion is over. So I hope still people to join and ask questions in the chat box that we can take up. I welcome our panelists again, Jyoti ma'am, Riti ma'am. I welcome you. We'll take your comments at the end. I'm sure Sampath is ready, but before that, I'll request Dr. Maya Gantayat to say a few words before we start. Dr. Maya Gantayat.
Thank you very much, Jan. I hope I'm audible.
Yes, ma'am.
Am I audible?
Yeah, yes, you're audible.
Thank you very much, Jan, for having asked me to participate in this meet. In fact, because although I'm a neurologist, people should be surprised that I'm so actively working with COVID. But still, I have had the opportunity. God has given us this opportunity to work with COVID patients. The point of the day. Now, this coming to Remdesivir, I find that for my own personal understanding, of course, this is the only antiviral drug, but the public, the people of this country, or at least in Odisha, they think that Remdesivir is a magic drug and it is going to heal them of everything. This kind of what I say, advertisements or talk in the TVs and in the YouTubes has given them a very, very skewed idea and thought about Remdesivir. So what I request the speakers to let us know, I know it is off-label and I know it is good or bad, God knows, but we should be clear and tell the public who should not receive Remdesivir. Now, if we are very sure of who should not receive Remdesivir, then we will be sort of little bit clearer that who can receive. I think that is what is my take. And I would request Dr. Sampath, Jayant, Dr. Jayant and CBK and all of you are younger to me, so I can call my name. So I would request you to be clear as to who should not receive Remdesivir. I think that will clear a lot of things.
Thank
Either
you.
whether it is mild or more severe.
Thank you, ma'am, for that comment. In fact, from madam's suggestion only, we have taken up this topic, and I requested Sampath because he is the clinician to decide the remdesivir therapy. He can tell best, and he can convince people the right situation when we should use and what are the real benefits and what are the real challenges with this talk. So thank you everyone. And with this, we'll go to the presentation of Dr. Sampath. I request Dr. Sampath to share his slides. Start.
So am I audible, sir?
Yes, Sampath, you are audible.
Okay. So thank you, Jan sir. Respected my madam, Jyoti madam. So today's topic, what we are discussing is remdesivir, right? So there is so much of confusion, which madam has already told, that who are the patients where we should use, who are the patients whom we should not use. There is also a question about the social fact that people are asking, like Sibika sir has told, that people are asking whether my patient is receiving remdesivir or not. So I think that if as a consensus among all of the doctors, if as a consensus among all of the doctors, we can give a single statement to the society that this is the patients who should receive remdesivir and this is the patient who should not receive remdesivir, because I always feel that a confusion is made more by other doctors rather than the patient relative, because they are the ones who ask the patient relative, are your patient receiving remdesivir? So I think this is something which as a doctor community, we should all come to a consensus and say to the public what is correct, what is wrong. We should not be more of an emotional aspect, because if as a doctors community we give the guideline, then that should be accepted by all. It should not deviate that okay, we give a off label or we should give some patients and see. That should not be the fact. So starting with my slide, you can see this is a very beautiful scenery and such a blue sky and everything. So if I say that this is the city where this started, that is the Wuhan, or this is the scenario of the Wuhan city where this nightmare for the whole world started. That is for the COVID, which we are struggling since last 1.5 years or more, and it's going to continue for a more time, we all know. But at least to be in a good part also, that is cases are decreasing, the intensity is also coming down a bit. That's a good thing. So talking today is that I'll be talking that remdesivir is not a magic bullet. So I will try to prove at the end, or try to give a justice to my topic, that end of it I should be able to make clearer that who are the ideal patient for remdesivir and who are not, whom we should give, whom we should not. This is what I will try to convince others, and at least we can come to some consensus that where remdesivir stands. Now, talking a bit about COVID, it's just for the sake of the presentation, I'm telling that it's a novel coronavirus that has emerged in Hubei province in China in late 2019. That's more or less in December 2019 it started. Coronavirus is a large family and it mostly causes common cold in humans, but sometimes these viruses change from animals to humans, and this jump or this change can actually give rise to this dreaded type of diseases. Similarly, like in 2003, which we have found that is SARS, we got 2012, there was a MERS. So this type of jump or change is normal, but it depends upon how severe it is and how we are able to control it. That is what something that determines the outcome of it. Now, it is a pandemic which is not going to end. That is what we are thinking, or the whole world is thinking. Why? Because so many people are affected. We have more than 23 million affected people, and that's huge. And we have actually lost many lives, both from the means those who are battling with COVID and those who are fighting for COVID, both from the doctors as well as patients. So we are losing life each and every day. That's something which is not a good thing, but still we have to fight it. And it is from the day one actually we are a race that is we are doing to develop a medicine or develop something called as a magic bullet, that okay, this is the medicine, if we can give it, the COVID gets cured. So that's something which is we are still lacking, and that's the reason we are having so much of lockdown, shutdown, and losing so much of financial part, which is also a very huge amount. These emotions and financial are two other aspects apart from the medical, which is also playing a huge role in this COVID pandemic. And this word or these two terms which are being used rampantly these days, that is off label or emergency, on using these two words, I think many doctors are a bit using unnecessary many medicines, that okay, this is off label, may help, emergency. So I think this word also needs to be a bit more stringent, that it is not off label, that whether this medicine will benefit or not benefit. So these two terms needs to be more precise, that why these terms have to be used and which are the medication to be used and where they should be used. That should be more strict in using this off label or emergency use medication. Now, COVID, we all know that 80% are mild or asymptomatic, 15% requires oxygen, and 5% are actually critical, which require ventilation. So this fraction is still holding the same from the day of the COVID started till right now also, even though the cases are very high, but percentage of this severity is still remaining the same and the death rate is still remaining the same. That is, we still get the same percentage type of distribution. And we have got a classification. We always try to classify COVID to mild, moderate, and severe. Mild, those who have a fever and no dyspnea or hypoxemia. Moderate are those who have a bit of mild hypoxia with increase in the respiratory rate. There is a bit of X-ray findings, and severe obviously are one who goes to the ICU and require a very high oxygen support. So I'm not going much detail of it because today I'll be more specific about my topic, what I'll be talking about. Now, Remdesivir. Why Remdesivir? How it came to came to this COVID management, that we'll be talking. It is a broad spectrum antibiotics which was developed by this Gilead company. It has shown activities in SARS-CoV-1. What we are dealing is SARS-CoV-2, or that is called as coronavirus 2. So Remdesivir has been shown to give benefit to patients in SARS-CoV-1, MERS-CoV, Nipah, respiratory, and Ebola, and all this. So all these RNA viruses are actually being benefited by Remdesivir, and emergencies have been approved by US, Europe, Japan, and India has given this approval against all these type of viruses, and it metabolizes into active form, which is called as GS441524. It's just a pharmacology of it. And where it acts, it actually inhibits the RNA dependent RNA polymerase. This is the target gene where this remdesivir acts and helps. Now, this is what we were doing it, or we were using this antiviral, the so-called antivirals in COVID. Now you can see that when a COVID viruses comes to ACE2 receptors, so this is how it enters, and if we can inhibit this viral or host interaction by AC2 inhibitors antibodies, so this is one step which were initially used. Then this endosome maturation inhibition was inhibited by hydroxychloroquine, which was thought so. That's why SCQ was the drug in the initial days for which India and America had a fight. So this is the area where SCQ is thought to act. It's thought to act, it's not confirmed. And then these viruses actually goes to translation, and here the protease inhibitor which were thought to act like lopinavir and indapavir. So this is where lopinavir was thought to act. Now again, this goes to RNA dependent RNA polymerase, and here what is thought the remdesivir to act. Now these are all the medications which were thought to act and have been used, but none has been proved to be benefit. And what I'm talking is that the mode or the area where this medication act is this. So this is the area where the remdesivir is thought to act and prevents further replication of the viruses, and hence releasing more viruses into our body. So this is the mechanism of action of remdesivir. Now, when did remdesivir has been thought that it benefits COVID? So this was the first study on remdesivir, which was published in New England Journal of Medicine in May 2020, May 22, 2020. This came in, and this was a double-blinded random controlled trial where around 1,000 odd cases underwent randomization, that those one who received remdesivir and one other placebo, and it was for 10 days. And the results, preliminary results were available. So you can see this is a preliminary result, and the primary endpoint was time to recovery, either the discharge from the hospital or infection control purposes, whatever it is, but it was the primary to recovery. And this was the result that came out, the interim result, which found that if you use remdesivir, obviously the median time of recovery is less compared to that of placebo. And if you use remdesivir, the mortality rate was found to be 7.1%, whereas it was 11.9% in patients where placebo was used. So after this study, actually things just turned up in favor of remdesivir, and it was thought to be a huge success, that this is a eye-opening study and this is the savior of this COVID. And following which, that is from May 22nd, actually after this study came out, the FDA and European Union gave a advisory to use remdesivir. So after this study, actually, they have given the approval that it has to be used in COVID patients with age more than, the FDA approval was for people with patients for more than 12 years with weight of more than 40 kg. And emergency use authorization also started to give for the pediatrics also to use at a dose of 3.5 milligram per kg body weight. But here they have clearly told that should be administered only in hospital or a healthcare settings that can provide similar level of care to an inpatient hospital. But this authorization or this use have not specified that who are the patients whom we should use it, who are the patients whom we should not use it, whether these are mild cases, moderate cases, or severe cases. So the authorization was only to use remdesivir for patients who are getting admitted to the hospital. That's it. So that is something which had many gray area which could not be answered. And once this has come out, the DCGI of India in 1st of June, actually on May 22nd, this studies came out, and in June, actually in the 20 of June 2020, have given the approval for its restrictive emergency use. But here also you can see that the DCGI injection was to use only in hospital institution to ensure proper use of the drug. That's it. There is no means data or no further advice that who are the patient whom to use and where to use. So on this basis, actually the first clinical management was included, or the use of remdesivir was included into the COVID management protocol issued by the government of India. Now they have given that it is to be used under emergency use authorization. That is on 27 June we got this protocol out into 2020, that you need to use it under emergency authorization, but there are some contraindications which you should not use. The contraindication was if your liver enzymes are more than 5 times the upper limit of normal, or you have severe renal impairment, or on hemodialysis, or if it's a pregnant or a lactating female, or children less than 12 years. So this is the guideline that has come, and the dose they have specified is for 5 days. So this study was for the study which actually created this remdesivir as a golden weapon was for 10 days, but with FDA and DCGI approved, and then it came to our clinical management protocol in 27 June that it has to be used for 5 days. But still here also there was no clear idea that who are the patient to be used, when to be used, where to be used. So we are still, any patient getting admitted to a hospital is asking for remdesivir. That's it. So that's why we are still in a bit of confusion. Now, as we understand more into the pathology, pathophysiology, the virology of this COVID, you can see that if you think that a day of the onset of symptoms is 0, now there is a viremia phase which starts at least 5 days prior. So the incubation period is thought not to be 14 days these days, it's only 5 days. That's why these days we say that if you got exposed to COVID, repeat a RT-PCR on day 5. So that's why we tell this thing. So it has been thought that most of the the average viral incubation phase is around 5 days, and the day of symptoms you develop, the first phase is called day 0. Now on day 0, actually the viral load starts to go up, or it increases rapidly. Now by day 6, actually the viral load starts to come down, but your inflammation starts on day 0 and reaches a bit of mild to moderate on day 5 to day 6. Now till here, what you can see that this is the area where you can suggest, or the peak of this inflammation, you can suggest that these are the patients where if you use remdesivir, this viral genome will get affected, or this viremia will get affected, and you get a better result. Now beyond 7th day or beyond 10th day, actually using remdesivir actually doesn't benefit you much, because by the time this 7th day or 10th day and the patient is bad, you can see there is no viremia. It's actually this inflammation that is playing a role, where the patient is either on high flow oxygen or critical. Now using an antiviral in an inflammatory cascade, or when there is an inflammation, or no one ever feels that antiviral is going to cure your inflammation. That is not the case. So we came to know that a cutoff day is actually 10 days. Now beyond 10 days of your first day of illness, please remember the first day of your illness is from the day your first symptoms have started. It can be fever, it can be myalgia, it can be cough, whatever it is, that is considered to be the first day. Now taking a proper history is actually very, very important, because that is what is going to help you to decide whether remdesivir will help or remdesivir will not help. Because you will have patients who are symptomatic maybe for 15 days and have presented to your hospital. So by that time, obviously you are very much sure that remdesivir is not going to help you, not going to help the patient, and will just increases the toxicity of the drug, because anything which doesn't have effect always have some side effect. So this is I would say this is one of my favorite slide, which says that beyond 10 days remdesivir has got no role. Hence always take a proper history before starting remdesivir. Now who are the ideal candidate if we talk about, that is if a patient is obviously a SARS positive and with a saturation of less than 94%, requiring supplemental oxygen, and there is a excess of pneumonia, is a candidate. And those who are COVID-like symptoms, that is you are not RT-PCR negative, but CT scan is showing a chloride of 4 and 5 with saturation of less than 94, is also a candidate to receive remdesivir. So please understand that remdesivir is to be given both in confirmed cases as well as in COVID-like syndrome, who have a saturation of less than 94 and have a chloride of 4 or 5. So these are the two ideal conditions where remdesivir to be used. Now the dosing, which we all know that it is to be given 200 milligram on day 1, followed by 100 milligram once daily for 4 days. Total duration is 5 days, and it is to be used in 100 ml NS to be diluted and administered over 30 to 120 minutes. Now why this range is that, usually I have found out personally, is that this loading dose of remdesivir causes a bit of thrombophlebitis. So my suggestion is that this loading dose of using 200 milligram, the dilution should be either in 250 or up to 500 ml of NS is adequate, because that's something which is a bit of painful, and you need to flush the line. So do not administer anything. If you are administering remdesivir at that time, do not use Y channel and other things, because there is a bit of interaction in that. So people have a tendency to use remdesivir with a Y channel with other antibiotics. That should be strictly avoided. Now in special situation, which we all talk about in pregnancy, previously it was a strict no. Now studies have found that it can be used with proper monitoring. Lactating mothers, obviously there is still not a yes or not a no, but you need to weigh that if you want to save the patients, then that should be used, because we don't want a very severe patient with oxygen therapy to be breastfeeding her child. That is not to be, that's not a fact also. So there is no question of asking a breastfeeding bad mother to feed her child during when she is in the hospital on oxygen. That should not be the fact. And obviously renal patient, do not use it if you have a EGFR less than 30 or patient is on hemodialysis, because I have found that few doctors are recommending that use remdesivir. Don't think about kidney, because the patient will survive and the kidney may go and patient will require dialysis. That is a very, very wrong approach. That should not be there, because we know that remdesivir, or we will be finding in our next slide that what remdesivir can benefit or will help. And in hepatic impairment, obviously it is a strict no if their enzymes are more than 5 times high. And children obviously less than 12 years, it was initially not recommended, but later studies have found that you can use it with a proper dose adjustment. And geriatrics actually caution is exercise, because they usually have multiple organ a bit in a compromised state. That's why you must get all your reports in your hand before starting remdesivir. That is a very important aspect, because if you are using remdesivir in geriatric patients, that is patients who are more than 65 or more than 70. So please get all your reports in your hand and then think of starting remdesivir. Now, there are some monitoring adverse effect and drug-drug interaction that has to be seen while using remdesivir, because people have complained of gastrointestinal symptoms like vomiting. Your enzymes, the liver enzymes, usually have been found to go up. So if you are using remdesivir, at least repeat liver function test every third day. It can increase your prothrombin time, and there is a bit of complaint of hypersensitivity reaction also. So we have seen, or I have seen on one patient where after remdesivir there was a generalized rashes type of reaction which requires this antihistaminic and steroids to control. And liver function, renal function, and prothrombin should be used in the monitoring. So the ideal advice should be is to use LFT or to repeat LFT, renal function, and prothrombin time every third day if a patient is on remdesivir therapy. So that's something which we should never forget about and should be there in our protocol. Now, when to discontinue? Suppose you have started remdesivir and your reports are available. So if your enzymes are more than 5 times, just stop it. That's very important. It is not that, okay, it is just because of remdesivir that the enzymes have gone up. No. So if your enzymes or liver enzymes are more than 5 times, just stop it. And there is any type of liver inflammation, patient is complaining of the right hypochondrial pain, or there is a bit of jaundice, or any liver dysfunction which or you think has actually started or precipitated, please stop remdesivir. And anything you find that this infusion related reaction like hypotension, nausea, shivering, vomiting, so you must temporarily withhold remdesivir. So that is something which must be told, sir, which CVK sir has already told, that it is not a very safe drug. It must always be administered under supervision. That is a very important aspect. So the remdesivir discontinuation fact is that these liver enzymes must always be monitored. Now in pregnancy, actually this NEGM study which came up in December 2020 actually cleared an idea about in pregnant females, where they used in around 86 pregnant and postpartum patients with severe COVID who received remdesivir. And they have found that it is very well tolerated with a very low rate of serious adverse event, and it was same as that of in non-pregnant females. So that's something which gives us an idea that it is also safe in pregnancy, where you must weigh the risk and benefit ratio of this drug. So it previously in pregnancy it was a no. Right now it can be used, but with supervision of the enzymes which I have told, because in pregnancy there is always a chance that you can have multiple problems related to livers, like HELP and other syndromes. So please use it with a bit caution. Now in children, actually this February 2021 actually gave a more idea that who are the patient where you can use, because previously it was a strict no for children less than 12 and weighs more than less than 40 kg. But right now this has been given to use at even the FDA have approved it in case of pediatrics and children's. That is, the minimum weight should be 3.5 kg, not less than that. And the dose is 5 milligram per kg body weight on day 1, followed by 2.5 milligram per kg weight for next 4 days. So in pediatrics or the infants, previously it was a no. Right now it is a yes, you can use it, but you have to calculate the dose and then use it. So the two previous contraindication which was thought that pregnancy, lactating and children's are actually right now, yes, you can use it, but you have to use it with proper monitoring and proper dose adjustment. So you can see that everywhere there was a yes, and this is right now the status. You can see everywhere it is a red bubble. That is, the cases are so high all throughout the world. We are suffering. Now, what went wrong? What went wrong? That on 31st March 2021, the WHO actually told, this statement was given, that is, it recommends against the use of remdesivir in hospitalized patients in addition to standard care, regardless of the disease severity. So this is a very important thing. This is a very big statement that the WHO has given, that regardless of the disease severity, don't use remdesivir. So why WHO have given it, on what basis it has given it, and that's something which was an area of concern, but we need to be very clarified, because today we live in a world where we talk about data, we talk about guidelines. So why WHO has given it? So let's see the 3 studies which were actually assessed, and on that basis let us decide that whether we should use or we should not use. Now, the first study is something called as the Act 1, that is Adaptive COVID-19 Treatment Trial. So what is Act 1? So this is a multinational placebo-controlled double-blinded RCT trial where around 1,000 odd cases were taken, where every exclusion criteria is given out. So patients who have all the exclusion criteria which I have talked are taken out, including the pregnancy and breastfeeding were taken out. They have been given for a disease or a dose for remdesivir of 10 days and placebo of 10. So the 2 arms were requiring 10 days. And the inclusion criteria were age of more than 18 years and patients who have a severe COVID pneumonia. Now, what the outcome is that actually it has found that remdesivir reduced time to recovery compared to placebo. So this was a very important thing. So the recovery was less. So in remdesivir arm, clinical improvement also occurs at a higher rate compared to that of the placebo. So if you in a remdesivir arm, the patients clinically improve a bit higher, but the important factor is that there was no statistical difference between the mortality on day 29 between the remdesivir and the placebo arm. So remdesivir do not give you any benefit in the mortality aspect. So it is not something which is going to save your patients. And this thing which I talked about is that the benefit of remdesivir was greatest in patients during the first 10 days after symptoms of onset. It is not beyond that. So patients who are symptomatic for more than 15 days, 14 days, presenting to your hospital, don't use remdesivir, because there is no data that it gives a benefit. And the result of the disease severity enrollment have been found that in very mild cases, there is no difference in their median time to recovery. So in mild cases who are not requiring oxygen, whether you use remdesivir or you don't use remdesivir, there is no difference. So both the scenario, the patient will recover in the same time. So it is just a wastage of remdesivir if you use them in the mild cases. Now in severe, in moderate cases, moderate means the benefit of remdesivir for reducing time to recovery was clearest in patients who require supplemental oxygen. That is, those patients who presented to your hospital within 10 days of your symptom onset and required oxygen are the ideal candidate for remdesivir. It is not milder ones. It is not those who are very severe, who presented very late to your hospital and are in ventilator. So this study gave an idea that remdesivir was most apparent in hospitalized patients on supplemental oxygen. That's it. And there was no benefit in mild to moderate COVID. So using this idea that remdesivir should be given from day one, or those who have a fever or those who have a normal oxygen saturation, remdesivir doesn't help. And those who have a late presentation, remdesivir doesn't help. So on this ACT study, we can got a clear idea that what is the time duration within which remdesivir to be used, and who are the patients where the remdesivir to be used. Now, WHO actually have come to a conclusion of stopping remdesivir with the outcome of this trial, which is called a solidarity trial. This is a very large study which WHO was monitoring. And here they not only monitor remdesivir, but they monitor all the so-called antivirals that can help, including hydroxychloroquine, including lopinavir, including interferon regimens. And they have given the outcome that whether any of it have little or no effect on hospitalized COVID, as indicated by overall mortality, initiation of ventilation, and duration of hospital stay. So it doesn't give you benefit in any way, whether it's mortality, whether we talk about ventilation free days, whether we talk about the duration of hospital stay. So this solitary trial actually is the basis on which this remdesivir being put into a big question mark, because this is a very large study. You can see it is around 11,000 odd patients. It's not 1,001 which was seen in Act 1. So in Solidarity was actually the largest ever trial that has come to an end with this month finding. And the primary endpoint was in-hospital mortality, and the secondary endpoint was initiation of mechanical ventilation and duration. Because initiation of mechanical ventilation is the fact, because in Act 1, we were talking that we should use it in patients who are moderate where oxygen being used. So obviously, if this patient deteriorates, it lands up in ventilation. So this was also the secondary endpoint which they have looked. And you can see the outcome is that the hospital mortality was same in both arms. Secondly, the initiation of mechanical ventilation was also same in both arms. So this Solidarity trial told, which was being enforced by Act, that you should use in oxygen patients where it is helpful. But the Solidarity trial told that the chance of a patient landing up in mechanical ventilation doesn't decrease if you use remdesivir. So the final thing was that remdesivir did not decrease the in-hospital mortality in hospitalized patient compared to that of your standardized care, and it also doesn't decrease the chance of your patient landing up in a mechanical ventilation, even though you have started in patients who are requiring oxygen. So this study actually have put a stop to use of remdesivir in COVID by WHO. Now, many people say that because the first study was talking about 10 days and this solidarity trial was talking about 5 days, so why not use remdesivir for 10 days and get the benefit? And it was also being used for 7 days, 10 days, depending upon the severity. And there was a bit of confusion that can we just increase the days of remdesivir. So this is also an article which was published in New Indian Journal of Medicine, and they have compared the outcome benefit in 5 days and 10 days course. Now, if you see, they have done in around 402 patients. So the outcome was that the in-hospitalized patient with severe COVID who were not on mechanical ventilation or ECMO or RDB treatment for 5 or 7 days have a similar clinical benefit. So this study with a number of around 400 odd cases have clearly shown that using a lengthier remdesivir injection for 10 days doesn't give you any benefit, and rather you make the patient prone to develop other organ dysfunction because of this drug. So there is no way it is recommended to use it beyond 5 days. So that is something which is important. Now coming to our last question, the first question for which we have started, that after seeing these 3 trials, one, the Act 1, which says that remdesivir is beneficial in moderate cases where there is an oxygen requirement, and the Solidarity trial, which says that it is not beneficial in any way. So where we stand, or what we can come to a conclusion of it, is that after all these 3 trials have come to a conclusion, you can see remdesivir has been conditionally approved. Till now, it is a yes to be used in UK and Europe with pneumonia who require supplemental oxygen, low or high flow, or other NIV at start of your treatment. Please remember, these are the new terms which have come up. With pneumonia who require supplemental oxygen or NIV at start of your treatment. It is not on patients who have presented in a gasping condition and being put on intubated state or ventilator. There, remdesivir doesn't benefit, and obviously these are the patients who present late to your hospital. So try to use remdesivir in a judicious way. And in US actually, still it is approved for treatment in adults and who require hospitalization, and has to be used also in children, but that is still the same. The guideline says that to use it in patients who require oxygen, not on milder ones. So the recommends in adults and children who are in hospital on supplemental oxygen, but not on any invasive mechanical ventilation. So this is one aspect that has come up recently, which says that if a patient is on mechanical ventilation or has been on mechanical ventilation being shifted to your hospital, or patients who have come in a very late stage on directly on ventilation, do not start with remdesivir. But if you have started remdesivir with patients on oxygen and they slowly subsequently changes to mechanical ventilation, maybe over 3 days or 4 days time, so complete your 5 days of treatment. So this is one aspect we say, that if you have started and maybe after 3 days of your treatment the patient goes to invasive, complete your 5 days of course. But if your patient is on mechanical ventilation from day one, remdesivir will not help you and should not be used. Now, where we stand in India, because till now WHO says no, US says in conditional stated, Europe is still using it. So where we stand, because this is a question after time, that are we unnecessary or irrationally using remdesivir, because that is creating a scarcity and that is creating a hue and cry among the public in this COVID management, because people are thinking that if they are not going to get remdesivir, they are going to get die, and that is a medical negligence. So as a doctor or as a healthcare practitioners, where we stand is that remdesivir is an experimental investigation drug which has to be used under emergency authorization use, which CBK sir has told that if you are using remdesivir, get either a verbal consent or a written consent from the patient. That is very important. We need to understand it is not a life-saving drug in COVID-19. Studies do not demonstrate mortality reduction with this drug, and has to be administered only in hospital settings, because these days people who can afford are getting remdesivir on a black market and using it at home, or stockpiling this medication at home, and that is not to be done, because we need to make people aware that it has its own side effects and has to be given under supervision because of the hypotension and infusion related issue. That is a very important aspect. And if you talk about who are the patients where remdesivir to be used, it is only to be initiated. I am talking, it is only to be initiated in moderately sick receiving oxygen and within 10 days of your disease symptoms. Not to be used in very mild cases, not to be used in patients who presented, who lands up immediately on ventilator or who get shifted to your hospital on invasive ventilation. So the area of remdesivir is only on moderately sick patients receiving oxygen during the administration to your hospital and who presented to you within 10 days of your disease onset, and that is, you can get it with a proper history. Never administer remdesivir in a home settings, which I have told that it's a drug which is not very safe and it has its own limitation side effects. So do not administer in a home setting, and this is the official documents of Ministry of Family and Welfare, Government of India. So with this thing, I hope that I was able to clarify some of the doubts and clarity there, where the remdesivir to be used and where not. So thank you all for listening to me patiently, and any questions we can discuss.
Thank you, Dr. Sampath. It was a very clear disposition, everything regarding remdesivir. I'm sure all of you have enjoyed, and he has touched every aspect, starting from the doses to the safety, to the indications, to the time of administration, to the safety guidelines, and all the trials in the associated with the drug is presented. and this presentation should have cleared almost all doubts that we had. I'm sure many of you have benefited from this. Now, I request our panelists to give their comment. To start with, Professor Jyoti Patnaik. Jyoti ma'am. Dr. Preeti.
Thank you.
Yeah,
Thank you, Professor Panda, for giving me this opportunity. Dr. Sampath, thank you very much for giving us this elaborative information about Remdesivir. Now, I want to add something. As you know, Remdesivir is a cytochrome P450 substrate, as well as it is an inhibitor of cytochrome P450 enzyme. That's why there is a lot of chance of drug-drug interaction. Okay, thank you.
Thank you, Dr. Preeti, for that comment. Professor Jyoti Patnaik has joined. Ma'am, your opinion on Remdesivir and any comment on the presentation? Yeah, you have to unmute, ma'am. Jyoti ma'am. Hello. Jyoti ma'am, please unmute. Ma'am. Sorry. ମୁଁ କରିଦଉଛି। Oh. Yeah.
Hello. Am I audible?
Yeah, you're audible, ma'am.
At the outset, I would like to thank Dr. Sampath for that elaborate presentation, clearing up many things, and about the utilization of Remdesivir in the right place at the right time. And as Maya Madam had requested to exactly tell when to use Remdesivir, that he has cleared very nicely. It is very, very important in moderate disease only when the requirement of oxygen has started. Along with steroids, we are supposed to use the Remdesivir. Not before, not after. It would not benefit the patient in any way. And that would be rather bad for the patient if we are going to use at the wrong time. So that has been very, very well cleared by Dr. Sampath Das.
Yeah, thank you, ma'am. And the final comment from Maya ma'am, Dr. Maya Gantat.
Thank you, Sampath, for this wonderful talk. One of your slides was really good. The one you have shown in a graphical manner, pictorial, where you are showing when patients are getting ARDS, when they are hospitalizing, and when the viral replication stops, and when the symptom starts. So basically, because Remdesivir is acting during the viral replication, and it does not act somewhat after the virus is gone out of the system. And we have all the cytokine storm and immunological disturbance and everything after that. And when we tend to see a lot of sick patients in dedicated COVID hospitals, I think we should refrain from using remdesivir in such cases and take a proper history and the duration so that we don't have any drug-drug interaction. Because definitely it has got a lot of problem with the hepatic enzymes. It's called, nowadays it's called amanitis because transamines, they increase. But what I would also ask one question, which I'm not sure whether I should be asking here or not. This remdesivir, what we get is, there is a little bit, after the expiry date, the drug control has given us that we can extend it. So, is the efficacy now same as what it was before the expiry date of the medicines? I don't know if this
Actually,
is
madam, they don't know the shelf life of the drug, and because they thought the initial 6 months is the pandemic that was initially fixed, and when there is a huge demand of the drug and the scientific evidence they gathered is it can be extended beyond 6 months. Officially, they ordered to change the expiry date further. So that was the situation why OSMCL was instructed to extend the expiry date. But I think it's very difficult to answer because we don't have any evidence of equipotency or decreased potency. I think Jyoti ma'am can tell better about this.
No, I also have no answer to that. I think the answer is the same, that they are not sure about it. So they have, initially, as you said, the shelf life was fixed at 6 months, and then they decided to extend it. I'm also not, I don't have any answer.
Yeah, Dr. Preeti, are you there? Because she is conducting a examination. Dr. Preeti.
No, our examination is over.
Yeah, over. Yeah, good. So we'll take your opinion. And does it happen that initially shelf life is fixed as 6 months and later is extended to 1 year, and there is official instruction to extend the expiry?
Actually, I don't have any idea. It might
That
be.
can, in general, that can happen with a injectable drug, antiviral drug.
Actually, I don't have idea. It might be due to the vehicle that is present, sulfobutyl ether beta cyclodextrin sodium. So I don't have idea actually.
Yeah. So I think ma'am has raised a very pertinent question. And actually, we know about the drug was spurious. Many industries were caught preparing spurious drug, but coincidentally, 90% people received the drug have recovered. So there is many confusion whether the drug was a placebo or the drug acted. I would prefer the interpretation as actually the drug had no role. So whether you give right drug or spurious drug, the disease healed himself and patients recovered, and patients were very happy that they received remdesivir. That's all, and in the process, few people gained some money. So there's so many questions on this, and in this time, we take years and years together to discover, use, and experience a drug. And we've seen how many drugs have come and how many drugs have gone in the process of pandemic. So very difficult to answer ma'am's question, and I'll definitely ask it to experts in different webinars if we get a right person, and if I gather some information, I'll pass it on to the house and especially ma'am.
Thank you.
So I think we had a very successful symposium, and remdesivir, everything has been discussed well, and the message is very clearly given. Thereafter, we have recorded this session. This is also streaming in YouTube, and we'll also circulate it to different hospital groups so that doctors who have missed the program because of their workload can also watch, because it's a very good presentation. Many positive feedback have come in message to Dr. Sampath, and it was so exhaustive. There is nothing to understand or misunderstand or not understand. So we have taken the expert comments, we have taken DMT sir's comment, and we have taken everybody's opinion regarding this, and this perhaps becomes clear with our audience that what has been discussed is the indication and should be very judiciously followed during the pandemic, so long it is there. So
One more
before,
question.
yeah,
Just one
yeah,
more question.
yeah, ma'am.
Yes, Dr. Sampath, this is to you. There has been a lot of talk on these monoclonal antibodies, working monoclonal antibody in COVID-19. Remdesivir plus monoclonal antibody does a wonderful job. What is your take on this?
Personally, if you ask me, I have never used this type of combination. So as per the literature, obviously it has been shown that it helps or it benefits, but that whatever benefit, it's still the answer is same, that it has to be used within the window period. So if we use, whether it is only remdesivir, whether it is remdesivir monoclonal antibody, so whatever it is, it has to be used within the window period, and that to the target population. So that is something which is an important fact, which I also do agree that if we use it, we can benefit. But we need to have a two-arm study where there will be only remdesivir with remdesivir and monoclonal antibody. So I'm still looking one such type of study to be able to give more clarification into the fact. But yes, studies have found that if we use both of it in the right time, in the right patients, we can get a benefit, madam.
Can I just?
Yeah,
Can I
ma'am.
just put in a word?
Jyoti ma'am, yeah.
So there are many studies that have shown that baricitinib with remdesivir is a good combination. And baricitinib is being used where steroid cannot be used. If there is any contraindication to the steroid usage, there they have used monoclonal antibody like baricitinib and remdesivir and seen that the positive outcome is there in those patients. But those studies are very small, and though the recommendation, again an off-label recommendation is there, we can use that particular baricitinib with remdesivir. That is at present, that is as far as we know.
Yeah, we have also experience of baricitinib and remdesivir, and it has steroid sparing effect. And we
The problem is that we are seeing prescriptions where steroid, baricitinib, and remdesivir all are being given. That is the problem.
and tocilizumab and
It is very
Clexane.
clear that it should not be given when steroid is there. When steroid has to be spared, there we can add baricitinib.
Yeah, that should be the message. But I think final word in the COVID management has not yet pronounced, and only future will say how far we were rational or how far we were irrational. So I'll request the panelists for their final opinion before we close, because it's approaching 5 o'clock, and there is a clear message, and this will educate many more people. And I'm sure all of you have pressing work. Don't want to extend further. So final opinion from our panelist, Dr. Maya Gantat, Professor Jyoti Patnaik, and Professor Priti Das.
I feel that proper history to be taken. We have to clearly take the doctors who are treating at the primary level should actually mention when did the fever start, when was the first symptom, so that we are very sure when we are using the window period to give remdesivir. Because most of the referral letter will just write SOB, fever, COVID positive. We have no clue. And the patient is not in a position to say anything because he is having breathlessness. And the attendants are not there, of course, because we are COVID patients. So my final request To all the doctors who are listening and to all the doctors who are taking care of COVID patients, all those who are referring, they must take the history adequately and mention the onset of the symptoms.
Thank you, ma'am, for that very valuable piece of information. Professor Patnaik.
I agree with ma'am. That is the constraint that we are also facing when we are treating these patients. We do not know at what level the patient is, because Remdesivir has to be prescribed when we are just going to prescribe steroids along with steroids. And that is just when the patient has entered the moderate disease, is in the moderate disease. And sometimes the patients are coming almost at 11th day, 12th day, and by then we do not know that the patient has completed 12 days. There really we have problems. So I agree with ma'am completely. We need a very good history before we start this. We can start this drug at our end.
Thank you, ma'am. Dr. Preeti, you want to say something?
I completely agree with Maya ma'am and Jyoti ma'am.
Yeah. So the rational use of drug, always pharmacology department has stood for the pharmacovigilance. So
Yes.
anything to do with pharmacovigilance here with Remdesivir?
If we get any idea, then we will send that message to our higher authority.
I think world over there is a lot of abuse of Remdesivir now, because as has been discussed, there is a hue and cry and pressure from the patient's party, from the people around, social pressure, political pressure for Remdesivir. So the pharmacovigilance should raise something regarding this repurposed or the off-label drug use. So I think we have touched upon every point we wanted. I must thank our panelists, Dr. Maya ma'am, Jyoti ma'am, and Preeti for the active participation. And Shampad, I know you must, you will do justice to the topic, and you have done very well. You have given a latest update on Remdesivir, and this has cleared the doubt of all our delegates, and this will also be circulated. And I must thank Professor CBK Mohanty, Professor Brajadash for their introduction, and also our Dean, Superintendent, and Department of Health and Family Welfare whole capacity building team. And it was a very useful session, and it will go a long way in educating our doctors treating COVID. Next program on Friday instead of Thursday we have put, because of the cyclone. I think cyclone is bringing some noise also in the background. So for the ensuing years, the cyclone, we have postponed it by a day. I will put it on Friday, where our speaker is Professor Prashant Raghav Mohapatra. He is touching upon an important point, the changed guideline in investigation and the management of the patient, especially the markers and the drugs. He's again touching upon this. Is along with the Government of India and Government of Odisha, we are doing this training program in the name of Center of Excellence webinar, or CME.
What will be the time?
Time will be the same, ma'am. 3:30 to 5. 3:30 to 5. This is on
Because
Friday.
he's coming as an examiner to our department.
Yeah. And he will be here only in your department. So he will come to the telemedicine and he will present. I think Thursday and Friday both he is with you only.
Yes.
So he told that I'll be part of SCB team presenting from telemedicine. So the AIMS director is giving a, Geeta ma'am is giving an introduction, and this is the first webinar of its kind where Government of India and Government of Odisha along with NHM and SCB and AIMS as partners launching the programs, where a team from SCB will be there and team from AIMS will be there, and all further programs will take up in this manner. And we are also releasing modules on short topics for the reference of our doctors who don't have much time to attend the webinar, they can download and update. Suppose Remdesivir, they can immediately download and update, and they can get the knowledge there. So thank you all for the cooperation. Hope together we can fight it out and win in the race. And thank you especially the speaker, Shampad, and all our learned panelists, Ma ma'am, Geeta ma'am, and Preeti. Thank you. Thank you, everyone. Take care. See you again on Friday, 3:30. Till then, bye-bye.
Thank you. Thank you.